Okay, well, I'll go ahead and get started. So this is always a huge topic, and certainly we can talk about breast cancer for hours upon hours. And a wonderful thing is that in 2022 there was a lot of new and exciting data, and these are probably things that you've heard of with HER2 low and some of the new medicines that are coming out. So I just wanted to give some in-depth information with some of the really impactful new drugs that we have data for in 2022. And then certainly if there's something you have questions on or something that you've heard or read about, we can certainly answer those questions at the end. So, like I said, it was a big year. There's a drug called TDXD, which I'm sure many of you have heard of. The other name for this drug is HER2, and it's really been an exciting year with the data for this drug, both in HER2 positive patients as well as what we call HER2 low, which is kind of a whole brand new definition that we've created just because of this drug. Sacituzumab or Trodelvy is a drug that has been approved for triple negative disease, but this year there was some data with this drug in ER positive disease. Just kind of run through some of the more recent studies with triple negative, and then also talk about a class of drugs called SERDs. There are a number that are being studied right now, so I think it's important, especially if you have ER positive disease, to know about what these drugs are doing and what might be an option. So this TDXD drug, the other name for it is trastuzumab deruxtecan. So the T stands for trastuzumab, and the other name for trastuzumab you may have heard of is Herceptin. So Herceptin has been around for a really long time, and it's been a revolutionary drug for patients with HER2 positive disease. And many years ago, this drug was created, trastuzumab emtansine or TDM1, or Kadcyla. And what this therapy is what we call an ADC, or an antibody drug conjugate. So the idea is that you take an antibody, and to that antibody you link chemotherapy. So the hope is that chemotherapy is going to be delivered in greater concentration right to the cancer cell, which will hopefully lessen some of the systemic toxicity, but also really help to get the treatment to where it's needed. So this technology is really exciting, and I think we'll continue to see other agents that employ this technology. So again, the T is trastuzumab or Herceptin. And TDM1, this DM1 or emtansine, is a chemotherapy drug that targets microtubules. So microtubule agents are typically your Taxols, your Taxoteres, your Vinca drugs kind of work in this area. So this is a very common place in the cancer cell that we can target. So if you remember back to high school biology, the microtubules kind of line up and then the cells split. So essentially you're stopping that process of cell division. So the difference between trastuzumab emtansine and trastuzumab deruxtecan is this deruxtecan drug is a different type of chemotherapy. So this is a topoisomerase 1 inhibitor. And topoisomerase 1 and topoisomerase 2 are drugs that we use in cancer treatment. But the idea is that you're able to really deliver the chemotherapy where it needs to go. So the drug to antibody ratio is important. And what's important about that is that when you look at TDM1, this is 3.5 molecules, or kind of the measurement of the chemotherapy drug to the trastuzumab, whereas the deruxtecan is 8-to-1. So essentially you're able to deliver more chemotherapy to where it needs to go. The other thing that's interesting about the TDXD compared to TDM1 is that there is a tumor selective cleavable linker. So once these antibodies bind to the cancer cells, they essentially need to get into the cancer cell to deliver the chemotherapy. So that linker is actually a really important part of the technology. And the other main differentiator with TDXD compared to TDM1 is this bystander anti-tumor effect. So basically, it's not just the cells that are strongly HER2 positive where that trastuzumab is binding, There's cells that can bind more weakly, and because there's a better payload and a better cleaver, it can help in cancers that are also not HER2 positive. So the TDM1 or the Kadcyla only works in HER2 positive cancers, but the TDXD can work in cancers that have less HER2 positivity. So this is really the crux of why we're seeing this drug work in this setting. So one of the big studies that we had with TDXD was this Destiny Breast 03. And this was a study that compared the two drugs that we just learned about, the TDXD with the TDM1. Now, this was only in our HER2 positive, and I apologize to the HER2 positive ladies because I don't have a lot on HER2 positive disease today. That we can certainly have another day and another lecture on that, but this is the one thing that I wanted to mention for HER2 positive. So the TDM1, this is our Kadcyla, our drug that a lot of HER2 positive ladies are on. And in this study, half of the women got the TDM1, or patients, I think men were included in this study as well. And the other half of patients got TDXD. So these were all patients who were metastatic, HER2 positive. They'd already had Herceptin, they've already had taxane, and they were allowed to have brain metastases. You know, some studies, some clinical trials exclude patients with brain metastases because we have to worry about drugs getting into the blood-brain barrier. But this study did allow brain metastases if they were treated. And the question was, did people live longer without their cancer getting worse because they took this medication? So what we found in this study, and if you read any of these scientific journals, you'll see this type of graph. And this is what we call a Kaplan-Meier plot. But essentially what we're looking at here is time and the amount of people who are alive and without cancer progression. So essentially, when you're looking at a drug, you want to see these two graphs be as far apart as possible. So kind of the way we think about it is if you can drive a truck through those lines, that means that the drug works really well. If you can slide a sheet of paper through those lines, that means there's probably not a lot of difference between the two agents. And then what's calculated is something called a hazard ratio. So the hazard ratio is the proportion of people or the proportion of subjects that you're able to tell how well the drug works. So essentially with this hazard ratio of 0.27, that means that there was a 73%. So you'll minus that from 100 or 1.0, and that's the percent difference between the two arms. And typically when we think of a good drug, the hazard ratio kind of starts at about 0.8 or 0.75. So if you think about aromatase inhibitors versus tamoxifen, that hazard ratio is like 0.8, 0.75. But the smaller this number is, the better the drug works. So to see this type of hazard ratio at 0.27 is very highly statistically significant. The other thing that we look at when we're looking at clinical trials is something called the p-value. So the p-value is kind of the measure of the statistical significance. And this number you want to be small. And for most studies, statistically, to know how big of a sample size you need, you have to know what kind of benefit are you looking for and what statistical power do you want. So generally, kind of the bare minimum p-value is 0.05. So this p-value was 6.5 times 10 to the minus 24th. So if you think about like your kid's scientific calculator, it couldn't even all fit on the screen how statistically significant this was. So the smaller this number is, the better the drug works. So the other thing that you can look at is this progression-free survival. So how long was the patient on this study and alive without their cancer getting worse? Okay, so this means that the drug was essentially a measurement of how well the drug is working. So on the patients who were getting the TDM1 or the Kadcyla, their progression-free survival was 7.2 months. You could see this ranges 6.8 to 8.3. But when you look at the TDXD or the Enhertu, this number was 25 months. So essentially a difference from 7 months to 25 months with the Enhertu. So another huge benefit. So we don't see results like this often in oncology. So to see this degree of benefit of a new drug was extremely exciting. And that's why if anyone's HER2 positive or knows someone who is, I'm sure they've heard of this drug. So what we're doing now with this drug is studying it in early stage patients. So people who have not become metastatic yet, because we think it's probably going to work better than what we already have. So it's an exciting drug. Now, the other part of that is, what about side effects? So the big problem with Enhertu, it is a fantastic drug. It works great, but it has this rare toxicity that can be very serious. And this is something that we call ILD, or interstitial lung disease. And basically, this is pneumonitis, or a lung inflammation. Now, fortunately, it's pretty rare, but if it happens, it can be a big problem. And this was the phase 3 study of TDXD, but in the phase 1 and the phase 2 studies, they actually had some deaths related to this lung toxicity before we knew how often it was seen and how to look out for it. So with this being said, right now we're seeing about 7% of people who take the drug can have grade 2 toxicity, 2.7 grade 1. So the difference is grade 1 is lung inflammation that's only picked up on CAT scan, but no symptoms. So say if you just happen to have your every 3 or 4 month CAT scan and it showed the lung inflammation, then we could treat it and you could potentially go back on the drug. The problem is this grade 2, which is unfortunately where most people present, which means that all of a sudden you've got a cough or shortness of breath or something that's different with your breathing. And then we do a scan and the scan shows the lung inflammation. Now, if this happens, the unfortunate part is we have to stop it. So if you fall into this 10% of people, specifically this 7.8% of people who develop the lung toxicity, you have to come off the medicine. So definitely if you're on this drug and you get cough or get shortness of breath, and we're just going to see this more and more as more and more people are getting this new agent, it's really important to look out for this. And I've had a handful of patients who have developed the lung toxicity. Luckily, they've all gotten better with treatment, but you have to look out for this. With the Kadcyla or the TDM1, we don't have lung toxicity, or extremely rare. So that's a big, important thing to know about the Enhertu. The other thing to look at is the heart toxicity. So as far as this goes, the heart toxicity is slightly higher, but again, it's usually very low grade, meaning that we might see a small drop in the ejection fraction, but it doesn't actually result in heart failure. So this is like the Herceptin, where it can cause the heart issues. Same thing with this drug. So it's basically Herceptin linked to chemotherapy. So these are two important things with this new medicine. So unfortunately, that really nice response we're seeing does come at a cost. Now, this brings us to June of 2022. And basically, when we have these big cancer meetings, so this ASCO is the American Society of Clinical Oncology, and it's been remote for the past few years. So this year it was not remote. So it was nice because, everyone could get together and attend the meeting and go over the results. But this particular presentation had a standing ovation, and to get a standing ovation at a cancer meeting is like a huge deal because, we're harsh critics and we really want drugs that can meet certain standards. So it's not something that you see every day. So to actually see this was pretty exciting data. Okay, so why are we so excited? So it's that same drug, that TDXD, that we just saw for our HER2 positive patients. Now, the problem is only 15 to 20% of patients with metastatic disease are HER2 positive. The remaining patients are HER2 negative. And the way that this study, remember how that payload was different and that linker was different? So the idea was that you didn't have to be HER2 positive only for the drug to work. If you had even a little bit of HER2 on your cancer cells, maybe it would be enough. So what they defined as HER2 low was 1+ or 2+. Now, normally if we saw 1+ or 2+ on a path report, we'd just glaze over it and it would be considered HER2 negative. But in this study, this was the group they were targeting. So if you go back to your old path reports, or if you've had a recent biopsy, you'll be able to see what your HER2 is. Now, sometimes we just do HER2 FISH testing. And if you do HER2 FISH testing without the IHC, you actually have to go back and do the IHC, which we've started to do. So with this, what's important is it's not just 15 to 20% of metastatic patients. It's actually an additional 65% of all of the metastatic breast cancer patients who are potentially eligible for this drug. I'm going to skip through this slide. So this talks about the linker, some of the things we went over. So this study was HER2 low. So HER2 1+ or 2+ patients with metastatic breast cancer who had had 1 or 2 prior chemotherapies. So say, for instance, if someone gets Taxol and then Xeloda, they could go on this. The Ibrance and those drugs did not count, but you had to, but that's something that they captured, whether or not you've had Ibrance or Verzenio, one of those medicines. And then patients were randomized. So this is a 2-to-1 randomization. So you either receive the Enhertu, the T-DXd, or patients received what's called treatment of physician's choice. So this is just any of the standard chemotherapies that we would do. Your Xelodas, Halaven, Gemzar, Taxol, Abraxane, kind of all the standard things that we would generally use. Now, importantly, the majority of the patients were hormone receptor positive. So the majority of the patients were ER/PR positive. So what we found in this study, I'm just going to keep going here. So to let you know about the types of patients who were in the study, most of the patients had liver mets. So about 70% of patients had liver mets. About 30% of patients had lung mets. The overwhelming majority of the patients were hormone receptor positive. So the true triple negative patients who have a HER2 of 0 would not have been eligible for this. But sometimes the triple negative patients are actually a HER2 that's 1+ or 2+. So those ER negative patients could go on this study. When we look at the amount of prior treatments that people have had, this was a pretty heavily pretreated patient population. So 2/3 of patients had had multiple lines, more than 3 lines of systemic treatment, and most people had had chemotherapy as well. About 70% of patients had had a CDK4/6 inhibitor. Those are your Ibrance and your Verzenio medicines. So what we found that was so exciting about this study, and remember, we want this hazard ratio to be low and we want this p-value to be low. So when you look at the difference, either in all patients or in the hormone receptor positive patients, you can see that there's a big difference between the standard chemotherapy and the T-DXd. So essentially a 5-month improvement, which correlated to a 50% improvement. So this new drug, this T-DXd, worked 50% better than the old chemotherapy, even if you weren't HER2 positive. So these are your HER2 1+ and 2+. And again, this p-value you can see is less than 0.0001, so very low p-value. So this is something that we are excited about, particularly when we look at how long this treatment is working for some patients. So you can see that almost half of the patients, a little bit less than that, were still on this medicine at 2 years out. In terms of the overall survival, when we think about those numbers, it's different depending on the type of disease that you have. But ultimately, we want people to live as long as they can with their metastatic breast cancer. And in this study, basically patients were living, 6 and 7 months longer than people who are just getting our standard chemo. So definitely seeing some nice results here. This was looking at the patients who were the triple negative patients or the HER2 low ER negative patients. And that group of patients did better too. So again, about a 50% improvement compared to our standard tried and true chemotherapy drugs. This again looks at some of the differences to see if it mattered if you were ER positive or ER negative, if you were the 1+ or 2+, what part of the world you lived in, and all of these arms favored the TDXD or the Enhertu. Looking at the amount of patients who responded, half of the patients responded compared to just 16% with the treatment of physician's choice. So response means that your tumor has to shrink enough to consider it a significant rate. And then the clinical benefit rate includes patients with stable disease. So 70% of patients had either tumor shrinkage or stable disease, which was the majority of people in the study, compared to about a third of patients who were just getting the standard chemotherapy. Now, the one thing I want to get to is the side effects, because definitely when you're thinking about being on a drug for years, you want it to be tolerable. So things that we do see more of with the TDXD, there's more nausea compared to standard chemo. The fatigue is about the same as standard chemo. In terms of low blood counts, it's actually not as bad. So chemo has more trouble with blood counts than this medicine does. Some patients can have some mild liver effects. You do potentially lose your hair with this medicine, and that's different than the TDM1 or the Kadcyla. Some patients will have vomiting more in this compared to standard chemo. So it's a little bit of a toss-up. So some side effects are less with this, some side effects are more. And then importantly, when we get to the lung toxicity, so we already talked about how important it is to look out for any lung damage while you're on this chemotherapy drug. And this was about the same, about 12%. In the previous study, we saw about 10%. So unfortunately, there are going to be some people who develop this. In this study, they did have some serious, so grade 5 toxicity is people who pass away because of the treatment. So this is, we never want this number to be anything but 0, but there were some deaths on this study because of the drug. So importantly, that's again, for the physicians, for the nurse practitioners, for the patients, the nurses, any type of lung change, cough, shortness of breath on exertion, anything like that needs to be investigated when you're on this medicine. So with this, again, this study established the TDXD or the Enhertu as the new standard of care in patients with HER2 low, either hormone receptor positive or hormone receptor negative metastatic breast cancer. So really kind of amazing results that we're all very excited about. So this will be a drug that you'll hear more and more about as time goes on. So to speak briefly about triple negative disease. So we talked about HER2 positive, we talked about HER2 low. We'll spend a little bit of time talking about triple negative disease. And this is our kind of standard laundry list, so to speak, of chemotherapy drugs that we'll use. Drugs like adriamycin, Taxol, Xeloda, etc. Now, one of these drugs that's newer is the sacituzumab drug or Trodelvy. So this is another drug that if patients are triple negative, or we'll also go over some data in ER positive patients as well. And this is another one of those antibody drug conjugates where you're kind of delivering the chemotherapy right to the cancer cells. One thing that I would mention is this idea of doing biomarker testing. So if you've had anything like Foundation Medicine or Oncomine or Tempus or Guardant, or there's a number of different genomic tests that are out there, sometimes you find something that's important. So the BRCA genes, those can either be inherited or they can also be something that's an acquired gene mutation or what we call a somatic gene mutation. The PD-L1 for the immunotherapy is still important, especially in triple negative disease, to identify patients who would benefit from Keytruda. This NTRK fusion, this is really interesting. This is a gene that we actually have therapies for, this entrectinib and larotrectinib. This we see pretty uncommon in breast cancer, only about 1% of patients, but if you find it, it's a target that you can use. MSI high or deficient MMR, this is also rare, but if you see it, it's something you can use. And this is something that we actually see a little bit more frequently in the clinic, something called TMB or tumor mutational burden. So if you've had any of those tests done, there should be a line that says what the tumor mutational burden is. If this is over 10, then you can consider using Keytruda or pembrolizumab in that setting. So these are all what we would consider to be actionable mutations. One thing I just want to mention briefly is olaparib or Lynparza. This is a treatment that's available for patients who have a BRCA or BRCA gene mutation. A lot of our clinical trials now in oncology are comparing the new drug to standard therapy. So the question is this going to work better than what you would have gotten outside of a clinical trial? As this 2 studies we just looked at had that design. So in terms of standard therapy, this was capecitabine, eribulin, or vinorelbine compared to the PARP inhibitor. And you can see in this study, there was a 42% improvement with the PARP inhibitor compared to standard chemo. So again, we're always looking to find things that are going to do better than what we would be giving anyways. And I realize these numbers aren't long. When you think about 3 months, it's like, well, what's 3 months? But the important thing to note is that's on average. So you're going to have people where that number is actually going to be much, much longer. So these small benefits are things that give more time and more time and more time. Certainly need to keep track of the side effects and what benefit is worth what side effects. Another PARP inhibitor drug is a medicine called talazoparib. So very similar results, about a 40+% improvement compared to standard chemotherapy. This is just a summary of our PARP inhibitor drugs. That's kind of a whole lecture in itself. We certainly have data with immunotherapy. There had been a drug called Tecentriq or atezolizumab, and this was approved based on the results of one study. There's actually some confirmatory studies that showed that the Tecentriq or the atezolizumab didn't work as well as we thought it did. So the company pulled their approval for it and doing some confirmatory studies. With Keytruda or pembrolizumab, this does have FDA approval. In order to get pembrolizumab, you have to get certain testing. So this CPS, this is a test that's done on the tumor. And if that score is greater than 10, then you would be a candidate for the pembrolizumab. So typically we give that in combination with chemotherapy, either Abraxane, Taxol, or gemcitabine carboplatin. So this is something that would be tested in your tumor if there's a disease recurrence. Okay, so let's spend some time talking about sacituzumab or Trodelvy. So this is a study that a drug that showed some really nice results in phase 1 and phase 2, and then the phase 3 study was performed. So this was almost 500 patients who had had at least 2 prior chemotherapy regimens. All of these patients were triple negative. And what was found is that there was a pretty significant, so this study had a 60% hazard ratio of 0.41, again, statistically significant compared to standard chemo. So in this study, the standard chemo was eribulin, vinorelbine or navalbine, capecitabine or Xeloda, or gemcitabine. So basically the sacituzumab or the Trodelvy worked better than people who were on the standard chemo, 5.6 months compared to 1.7 months. So these are all metastatic patients. And because of these results, we use this drug. It also works in patients who have brain metastases as well, which is important, particularly for triple negative disease. Now, in terms of side effects, if anyone has been on Trodelvy, they could probably speak to these. You do need to be careful about side effects, and I tend to incorporate dose reductions very early on. This is one of those drugs where it still works well, even if you need a dose reduction. So common things that we see are low blood counts, diarrhea, fatigue, nausea. So the GI stuff and the low blood counts. And again, oftentimes we will need to do a dose reduction because of these. So that's just something to note. If you're having a lot of side effects, it's always important to consider, are you on optimal medicine for side effect management? And can we do something with the dose? Now, what was exciting about this drug is similar to the TDXD. We know it worked in triple negative patients. What about other breast cancer patients? So this study was done looking at patients who had hormone receptor positive disease. The exact same design. So physician's choice of any of these standard chemo drugs compared to the Trodelvy. And just to give you a little bit of background about this drug, I apologize, I should have put this slide first. This is this TROP2 is a protein that is expressed on many different types of cancers, and about 80% of breast cancers have expression of TROP2. And it's interesting because they went back and looked at doing the TROP2 testing, and it's not something you have to test for. So if you're triple negative or if you're hormone receptor positive, you can just get this drug because the chance of having this TROP2 expression is so high. So going back to the study in patients who were hormone receptor positive, a couple things to note. These are patients, about 80% plus patients had liver metastases. Many patients had a prior CDK4/6 inhibitor. Many patients had prior chemotherapy. Patients had an average of about 3 prior chemotherapy regimens, but this actually went up to 8 prior chemotherapy regimens. So this is a pretty heavily pretreated patient group. And what they found in this study is comparing the sacituzumab to the physician's choice chemotherapy. There was about a 1.5 month improvement, but statistically, this translated into a 34% improvement with a statistically significant p-value. So maybe not as significant of results in ER positive patients compared to triple negative patients, but it's another thing that you can add to the repertoire of drugs that we can give. In terms of survival, this was not mature yet. So this is about a 20% improvement, but that's not statistically significant at this time. So we'll need to continue to follow this out. Now, in terms of side effects, so this is just something to note, is that about 30% of patients needed a dose reduction. About 60% of patients had a dose delay. So basically they came to get their treatment and the counts weren't high enough. So those are all things that can be managed with dosing. All right, so moving on to ER positive patients. So these are our standard drugs that we're using, your aromatase inhibitors, your fulvestrant or your Faslodex, CDK4/6 inhibitors, Ibrance, Verzenio, Kisqali, alpelisib or Piqray, your PI3 kinase drugs, everolimus. And a class of drugs that I'd like to spend a little bit of time talking about are these oral SERDs. So these are drugs that more and more patients, or more and more of these drugs are being studied, and ultimately more people will be receiving these. So we have a lot of data with the CDK4/6 inhibitors. So Ibrance, Kisqali, Verzenio. And all of these drugs work relatively about the same. So about a 50% improvement compared to the hormone therapy by itself. And when we look at how long these medicines work, it can actually work for a pretty long time. So 2+ years before the medicine stops working and we need to switch to something else. Now, we could talk about, is there an optimal CDK4/6 inhibitor? But I would kind of take the approach of, I think they're all pretty much doing about the same thing. Importantly, people who've been on Ibrance could potentially go on to receive ribociclib or could go on to receive abemaciclib. So having one doesn't preclude you from trying all three. The way that estrogen receptor positive therapies work. So these are your aromatase inhibitors. These are your Arimidex and your letrozole medicines. These medicines work by blocking estrogen before it even gets to the cancer cell. Now, the other medicines are working at estrogen at the level of the estrogen receptor. So the estrogen receptor is in the cancer cells. Estrogen binds to that and turns on things within the DNA of the cancer cells to tell those cancer cells to grow and divide. So our old drugs, our tamoxifen is a SERM. We have our aromatase inhibitors, which block estrogen here, and then we have this new class of drugs. So the fulvestrant or Faslodex is one of these drugs. And if you've ever been on Faslodex, you know it comes with a pretty decent injection that's given into the rear end every month. So the tough part about that is getting an injection every month can be painful. If people are on blood thinners, sometimes it's problematic. It also ties you to the cancer center. So the idea is maybe if you could get a pill form of fulvestrant, wouldn't that be great? So that's essentially these new class of drugs, these oral SERDs. Now, what's also really important about the SERDs is that one of the ways that aromatase inhibitors stop working is that this estrogen receptor can turn on without estrogen. So one of the mutations that we see in breast cancer that develops over time as cancers evolve is that you get mutations in the estrogen receptor that keeps them turned on. So it doesn't matter that you have an aromatase inhibitor, that receptor's turned on and it's going to continue to cycle those cancer cells. So where these medicines work is they block or they degrade the estrogen receptor. They completely get rid of it. So it essentially bypasses that resistance mechanism. So again, it's difficult to come in for injections. The idea is that these pills may be a better option, but also they may give you a different option beyond fulvestrant. So if you're having trouble with the shot, or maybe the fulvestrant has stopped working, these would be another option for patients. So this is a class of drugs we're really excited about. And one thing I would note to you is that when fulvestrant and the aromatase inhibitors are compared head to head, the fulvestrant actually works a little bit better. So not only do we think that these drugs may bypass certain resistance mechanisms, they just may outright work better. So with that being said, let's talk about this drug called elacestrant. So all of these SERDs, they end in STRANT. So if you see drugs that kind of end in that, then you know it's working with this mechanism of action. So this study looked at patients who could receive elacestrant. They had to have prior endocrine therapy. So this was more of an endocrine resistant population. And they could be randomized to either get fulvestrant, anastrozole or Arimidex, Femara, or exemestane. So this is kind of our standard hormone therapy drugs. Now, it's important to note that this study did not include Ibrance, Verzenio, those medicines. So this is just straight plain hormone therapy. And what was interesting about this drug is compared to standard hormone therapy, it worked better. So this hazard ratio was 0.7, so not real low, but it was certainly suggestive that it may work better than the hormone therapies we already have. And if you think too, if anyone here is hormone receptor positive, as you know, many times we like to ride out the hormone therapy as long as possible before needing to move to chemo. So if we've got another hormone therapy to line up and to put in that lineup of drugs, that's a good thing as well too. So importantly to note, this was statistically significant, and the amount of patients who were alive and without disease progression was higher at 1 year in patients who are receiving the elacestrant compared to standard. So this is a drug that's being reviewed at the FDA, and we'll consider to see this class. There's probably 5 or 6 different drug companies that all have one of these oral SERDs. So this will be a class of medicines that if you have ER positive disease, you are likely to see in the next few years. One other drug I would like to mention to you, these are PROTACs. So these are proteolysis targeting chimera. So this is also something that works at the level of the estrogen receptor. So this is a drug that in very heavily pretreated patient population, in a phase 1 study, there was about 40% of patients had a response or had stable disease. So this is yet another lineup that we'll have potentially for patients who are ER positive. So a lot of exciting new drugs, a lot of additional options, really some drugs that work extraordinarily well, and always new things coming along. So I think this might be it's my last slide, and I would be happy to stop and take any questions.
I am going to jump in just a little while because I had to jump out. She's still recording. So I'm going to ask a question that we had discussed before, and then I'll hand it off to everybody once we turn off the recording button. Okay. Does that seem like an okay plan for everyone? Okay. So we had a brief discussion before you came on, Dr. Puhalla. It was about, all the options that you have in treatment and making that decision, and how do you guide a patient in making the best decision for their treatment?
Sure. And it's a great question, and it's a really individualized question. So in part, I look at a couple things. I look at what type of treatment someone's had. I look at how quickly their disease has changed. So is it a setting where we've been able to stay on one therapy for a really long time? Or maybe it's someone where every other scan we're needing to come up with something new. I look at where the disease is. So if somebody's got maybe a couple bone metastasis, maybe that's a patient where I might give it a little bit more time than someone who has a lot of liver metastasis or a lot of trouble with their blood counts, things like that. So there's really a lot of different factors. So there's kind of standard things, so to speak. There's your Ibrance medicine, there's your TDXD, there's your Taxols, kind of your standard first line things. But even within that group, there's a lot of different things. So it really depends on how much disease, what someone's had. Absolutely patient preference. Sometimes it's very difficult for people to get back and forth to the cancer center, especially with some of our weekly chemotherapies. So maybe someone would prefer a pill. Maybe losing your hair and not losing your hair is important. So maybe you have a lot of neuropathy left over. So I'm going to pick something that doesn't have neuropathy. So it's not one size fits all at all, very individualized.
Okay. One more question came up. Again, I'm stretching this just since I've been, sorry guys. The question came up, and once we turn off the recording button, we can maybe expound on this. But one of the questions were concerns about kidneys. You had talked about liver problems, things like that, but there was a concern about the treatments on the kidneys. Do you have any comments on that?
It depends on the drug. So most drugs, I wouldn't say most, I would say many of our chemotherapy drugs have liver excretion, not kidney excretion. Part of the problem is not all drugs are studied in patients who have different degrees of organ dysfunction. So sometimes we'll actually do things called organ dysfunction studies, where you actually recruit patients who have organ dysfunction and study the drug in that patient population. Those are pretty uncommon. So a lot of clinical trials will exclude patients who have abnormal function. So you just don't know if a drug is safe, but maybe depending on what you know about it from animal studies or from early phase studies, how you expect the drug to be processed in someone's body. Say, for instance, if someone's on dialysis, it can be tough because not all drugs have been studied in dialysis patients. But most of the time, you have a pretty good idea whether or not the kidney function or the liver function would be an issue with metabolizing the drug and whether or not you can safely give it.
Okay. Let me think. Oh, there was another question, and I have a feeling we're just going to have to let go of this recording for anybody else to see, because we're going to have to move to everyone being open to asking any questions they may have. So I just wanted to clarify that. But there was a question about biopsying bone mets and is in that procedure. And I wanted to, if there's any additional question to that, feel free to ask it. But I wondered if we could talk about that briefly.
Sure. So the problem with bone metastasis is, depending on where they are, it can be technically difficult. So if something, say, for instance, on the inside of a vertebrae, that can be technically difficult. Ribs can be technically difficult. The other part is that because the bone is hard, sometimes it needs to be processed in a way that makes you not be able to trust the results on the receptor. So usually a bone biopsy can give you a yes, no, if it's cancer or not, but it can't always tell you if it's estrogen positive or estrogen negative. And a lot of times that's the whole reason why we're doing a biopsy, is to see, we're pretty sure it's cancer, but you need to know what type. So that's the challenge with bone biopsies, is that because of the processing of the bone biopsy, sometimes you can't trust the results of the ER and PR.
Okay. Colleen is on her way. She has two little ones. So she got called out and her husband's away. So she's kind of racing. She'll be there in a second to stop it. The one question I had regarding the bone mets, so the disease, does it change at all? Like, do you have, and when do you suggest getting another biopsy from maybe the first time that you received the diagnosis?
It's a great question. And yes, we definitely know that cancers change from primary to metastasis. So about 25% of the time, a cancer that was ER positive can turn ER negative, or a cancer that was